Hi, welcome to the exciting world of cardiology. This is Dr. Jaitly. In this particular video presentation, very briefly and basically, I'll be talking to you about the fundamentals of some new innovative techniques that have happened in this year, 2016, and the new world of various cardiovascular areas. Now, starting about more in the PCI world, if you will, where the percutaneous coronary interventions have improvised from bare metal stents to sirolimus or paclitaxel, which are drug-eluting stents, to complete bioresorbable stents. Now we have bioresorbable stents where the polymers, remember, there was always a problem with restenosis and rethrombosis in these areas post insertions of the stents into the coronaries. So as a result, what is happening is, over a period of time, we have been able to advance our stent technology to release a very slow, steady-paced drug, which is anti-proliferative, whether it is sirolimus or whether it's paclitaxel. Either of those two are very, very helpful within the arterial lumen so that the intimal proliferation does not occur, because neoatherosclerosis has been a huge problem in most of these stents that have been placed over the past several years. Despite the fact that PDCA, which was 30 years ago, when it came around, was using only a balloon to keep the artery from clogging and just push the plaques around. So we have come a long way, no question about that, even after the second generation drug-eluting stents. But bioresorbable stents is an extraordinary innovation in that the stents are deployed and the polymers are just resorbed within the walls. So there is no real quote-unquote foreign body chemical really to sort of generate an inflammation, if you will. So again, results will tell us in the next several years once the clinical trials get completed. But just a thought that bioresorbable stents are a great innovation in this technology of PCI world. Okay, so obviously the goal is to reduce post-insertion thrombosis and restenosis, if you will. Now in the valve world, moving to the right panel here, we know that mitral valve and aortic valves are constantly being replaced over the past several decades now, almost a half a century, where valve replacements have been done for mitral stenosis or aortic stenosis here, or aortic regurgitations or mitral regurgitations repairs, etc. So the whole phenomenon of putting it transcutaneously began almost about 8 or 10 years ago with the aortic valve first, where they could go from the aorta and place an aortic valve transcutaneously. And that has been extremely successful in moderate to high risk patients. So those are the candidates who really benefit from TAVR. But nevertheless, there was always zeal to see if mitral valve can be replaced in a similar transcutaneous fashion. And over the past couple of years, it has evolved to the level where now one can actually go from the femoral veins up into the inferior vena cava, pass a catheter through the interatrial septum here between the RA and LA, right atrium and left atrium, so creating a small little AST, if you will. And that catheter goes ultimately through the mitral valve, which may be stenosed or may require repair, etc. So the whole idea is wanting to see if you can actually deploy this mitral valve transcutaneously right here. And once that's deployed, the catheter is pulled out and you're set with mitral valve, literally with no surgery, no incision needed. So the goal is minimally invasive procedures specifically for moderately high risk candidates. And TMVR is now, is the technology or the innovation that is now in place. And results will tell us in the future clinical trials in 2017 and 2018 how these compare out with the routine mitral valve replacements that's done via open hearts. Now, in the pacemaker world, in the pacemaker world going from, that's a misprint here, in the pacemaker world going from lead to leadless pacing. Now what happens is when you have a lead to leadless pacing, shifting to my left-sided panel, the leads were being placed via the right atrium, and then the lead will be lodged within the right ventricle, right? And there'll be a whole lead always, sitting around in the subclavian area with a generator in the foci, right beneath your right or left clavicle. Now the innovation is so exciting that the leadless generator is all built in, and it is all right within this small little cylinder, which is almost the size of a quarter, if you will, 25 cents. Okay, that's why I've shown you the size here. It's that small, and that's deployed into the right ventricle, and it is deployed through the femoral vein approach. And once it's deployed, the catheters are obviously pulled out, and this guy just sits here at the right ventricular apex. It's nicely anchored in. So the greatest advantage here is the person within a couple of days can start driving, carrying on with the routine activities, as opposed to a person who had the right ventricle lead and dual leads, etc., placed through all these mechanisms of old-fashioned generators, we call them now. And the person could not raise his or her arm, could not participate into the gym activity, or even will be prohibited from driving for several weeks. Still, the whole thing is nicely organized and the pacemaker is nicely in place. So, I mean, we have come a long way now with the leadless generator pacing, where this is placed into the right ventricular apex, and it's a cutting-edge technology. Now, we certainly need to develop this even further. So what's going to happen is, I think, stay tuned for more advances or innovations that will happen, because remember, it's only pacing right ventricle. We need an atrial pacing, we need a ventricular pacing, and perhaps we might need a hybrid defibrillator soon. So those things will happen, and so stay tuned, because that's what is the next step in technology and research. Okay, so it's a minimally invasive procedure, and certainly minimizes the lead and pocket generator related complications that can ensue from the previously known pacing that we were doing with the leads. And lastly, in the lipid world, here moving to the right panel again, the lipid world, a new class of drugs called the monoclonal antibodies were awaited, and that's just been introduced this year with two major prototypes. And they are called PCSK9 inhibition, and they are monoclonal antibodies. So the concept is such that the autosomal dominant hypercholesterolemia has a mutant gene which tends to have a receptor complex between an LDL receptor sitting in the liver and the LDL cholesterol that is circulating in the blood. So as it goes inside, it tends to form a complex, and PCSK9, the higher the level, the higher will be the LDL complex, etc., this LDL-R and LDL-C complex to the surface of the liver. So as a result, higher will be the LDL-C circulation within the bloodstream, and we don't want that. So the whole idea is wanting to reduce the LDL-C, and you can only do that by inhibition of PCSK9. So PCSK9 inhibition, which is with a monoclonal antibody, it inhibits this complex to come to the surface, and therefore the LDL receptors, LDL-C cholesterol is reduced within the bloodstream. So that's another innovation after the statins, even though we had other groups of drugs called fibrates, then raisins and ezetimibe, and omega-3 fatty acids for, and nicotinic acid as well for triglycerides, etc. So those are very old groups which have been there for at least 20, 30 years. But the fact is that PCSK9 is in addition to the statins, where statins fail to reduce the levels of LDL-C to the desired range. Then in that case, PCSK9 inhibition can be used via monoclonal antibody injections, either once a month or twice a month, and as recommended by the drug manufacturers. Well, stay tuned for more exciting innovation stuff, and thank you for your attention. Appreciate it.